Good morning, everybody, and welcome to the South East Perinatal Mental Health webinar. Thank you all for joining us. I'm sure that we'll have some others joining in the next couple of minutes. So whilst people are joining, if I could just remind everybody of housekeeping. So please can people keep their lines on mute and turn off their video cameras unless they're presenting. Obviously, please use the chat function. Feel free to introduce yourselves in terms of job role and where you're joining us from today. Please also feel free to raise your hand in order to ask questions, share comments and reflections. And we are obviously recording the webinar today in order that people can watch it at a later date on the website if they're not able to join us this morning. So today we have our topic area for today is Start for Life. This is a great opportunity in order to look at the policy, but also how to put it into practice. So we will start off as usual with a national update from both myself and Jenny in terms of both kind of national headlines, but also resources and training available within the South East. Then we will have more of a focused area on Start for Life. So we will start off in terms of being joined by Professor Jane Barlow in terms of setting the context of why Start for Life is such an important area for us to focus on. Then we'll move on to John, who will give us an update on the Start for Life programme and talk us through the programme itself. And then we are joined by Bradford Infant Mental Health to show us what it can look like in terms of actually putting it into practice. So as usual, we have a really packed agenda in the next hour and a half. We will try to keep everybody to time. So we will give a 2-minute warning to speakers should we need to. And we may have to ask for some questions to go into the chat rather than being able to discuss them on the call, depending on how we're going with time. Okay. So if we just start off with our national update, so just a couple of things to headline really. So the ESME 3 final report has been published, and there was a workshop which many of you may well have attended on the 8th of September. The details of that are available on the NHS Futures collaboration platform. And then following on from that, the national team are looking for volunteers to help them revise the implementation considerations guidance and work on incorporating the recommendations from the ESME 3 report into the national guidance. So a call out for volunteers has gone out from Zoe, and they are asking people to contact Zoe directly by this Friday if you're interested in being part of that piece of work. So the psychological therapies for perinatal mental health implementation guidance, these are also now available on the NHS Futures collaboration platform. So the guidance is for the specialist community services and the maternal mental health services. There is a webinar being held next Wednesday, 2 till 4, which will complement the guidance, and we would strongly recommend that people sign up to that webinar. The link is included, and if there are any questions, that webinar is obviously being hosted by the National Perinatal Mental Health team, and you can contact them directly. At the moment, there is the Perinatal Mental Health Community Services Survey out, which is a short survey looking at the long-term plan extension to 24 months ambition and how the national team and the ambition can better support people with implementing that. It's a really short survey. It only takes about 5 minutes to complete, and the survey is open till next Friday. So we would encourage services to look at that. And the recommendation is that the service manager would complete that on behalf of their service in discussion with other team members. So please, if we could ask services to do that, that would be great. So I have put in a slide on provider collaboratives. I'm not going to go through all the detail on this, but really it's a plug to say that our topic area for next month's October webinar will be provider collaboratives. It's going to be a webinar that we will run in conjunction with the National Provider Collaboration team and the National Perinatal Mental Health team. But I guess really in the meantime to signpost you that the latest national guidance for the perinatal provider collaboratives, get my P's out, is now available on the Futures Collaboration platform. There has been an update in terms of the go live dates. So the go live dates were originally due to be October 2022 and the first, at the latest by the 1st of April 2023. In collaboration, working with our stakeholders, we've recognised that there are complexities in terms of implementation by those dates. So the new go live dates are either the 1st of April 2023 or the 1st of October 2023. There will be no further flexibility on these dates, is what we are being told, but we as regional areas can decide what go live dates we will be working towards in terms of those two options. There is also further information about the financial envelopes available. And obviously the regional teams ourselves were working with specialist commissioning, finance and non-spec com in order to look at that. And there will be an update which we will provide at the October webinar on the selection criteria, which is currently being developed at the moment. It's just in its final tweaks and sign off. So do please sign in for the October webinar where the main focus will be on provider collaboratives. So an update on our web beds migration. So the mother and baby units across the country have been involved in our migration from our current system developed in the southeast, which was NHS web beds, over to the new capacity planning and management system. So we've had a variety of meetings taking place for representation across the country, and there have been user acceptance testing meetings. There is now into the phase of training. So there are 2 repeat training sessions taking place on Thursday, the 6th of October and Thursday, the 13th of October, that are specifically for the mother and baby unit part of the system. You only need to attend one of those sessions, but you are welcome to join 2 if you want to have a recap, and the session will be recorded. And then the plan is that web beds will transfer over to the live system of the capacity planning management system on Monday, the 17th of October. So those of you in the mother and baby units would have had notifications about those training meetings, etc. If there is anybody that hasn't, please pop your details in a chat and we will send them on to you. But they are specifically for those that currently use the web beds tool. So just a little bit of a plug for training, and for national colleagues from around the regions that are on the call, just a reminder that these training events that I'm going to talk about are specifically available to our South East colleagues. And so do get in touch with your regional teams about what training and education is available for your region if you are not in the South East region. So within the South East, we have the virtual working training course taking place on Friday the 21st of October. We still have available spaces, so please do get in touch if you can register for that via the Perinatal Mental Health Academy, and you can sign up for that. We also still have places available for the cultural competency and safety workshops. In particular, the first 2 dates coming up are the 20th and 21st of October. So again, if you go to the South East Perinatal Mental Health Academy, you can find the full details of the training courses and sign up to them there. We still have our licence for the Gypsy and Traveller Cultural Awareness training. We have our license for a year, and so our ambition is to get as many people through that training as possible. So please, as a reminder, do sign up for that training. It's a really great resource. And then more specifically for targeted groups, we have the Making Birth Better birth trauma training. Now this is open to our South East maternal mental health services. So each of the services have been allocated places. There are still some available places, so please in your individual services look at if there is anybody else available that would be appropriate for that training. And also then just a final plug for the 5 to Thrive champions who have already been trained. You are now invited to do the next part of training, which is the Resource the Trainer course, of which there are dates both for at the end of this month in September and also November. So we'd encourage all the champions that have been trained so far to go on and do the next piece of training. So that's all the training in the South East that is already in existence and due to take place. And then just a reminder that we have been allocated money, as have all the different regions. So again, if you're not within the South East, do speak to your regional team about your allocation for your region. But within the South East, we've been allocated money for this year. We were due to have a training and education planning meeting last week, which unfortunately had to be postponed, obviously in respect to the national mourning period. That date should be coming out in the next couple of days for a rescheduled meeting in order to decide how we will use our funding for the rest of this financial year. And just really an ask of system leads and service leads to come prepared to that meeting in terms of having reviewed your workforce and what training and education you wish to have for the region this year. Okay, at this point, I'm going to hand over to Jenny, who's going to talk us through some of the other elements and resources.
Morning, everyone. Thank you, Liz. Oh, I'm just admitting somebody as well. I'm multitasking at the moment, so do excuse me. And the other thing to say, because this is bound to happen, it's called Sod's Law. I've had a text to say my passport is arriving this morning and will need signing for, so I can almost guarantee it'll be during my presentation. So apologies in advance if that happens. The first thing I wanted to mention was the Perinatal Pathways tool pilot. A lot of you on the call will be aware of this tool. Some of you might not be aware that we've extended it from being able to be used with women and birthing partners to dads and partners. And it's the dads and partners that we want to do a further pilot with to ensure that the tool works for dads and partners. As I think it could be a very useful thing to have in your armoury for the dads and partners ambition under the long-term plan. So if there are any services that would like to be part of the pilot, we're thinking to run it for 3 months. And if you're part of the pilot, myself and Jules McCoy, who's involved with me, will deliver training on the use of the tool to your team. So there is a bit of an advantage about being involved. So do get in touch if there's any services out there that would like to be part of the pilot. Next slide, please. I wanted to highlight these 2 resources that you may have come across. One is from the Maternal Mental Health Alliance, which is mapping specialist services. There's a short survey to be completed. It says by today, but I'm sure that they would still accept surveys if they came in a little bit after that date, but really important to get that data in because it will influence their next heat map, which was so influential with the further commissioning of perinatal services. And on the right, we have some a shout out for some participants for research from UCL, which is asking for health visitors, midwives and GPs, so healthcare professionals who aren't mental health by background, to look at ways of asking women about suicide. And the details are on that poster, but I thought that was a really important one to highlight. Next slide, please. Some further resources here, particularly of significance for our maternal mental health services. So on the left there, you have the 5 new national bereavement care pathways, and a link to those for those of you who are interested to have a look. And on the right, a paper on reviewing screening and prevention strategies for stillbirth. So again, an interesting and important one for our maternity and MMHS colleagues. Next slide, please. This is pretty amazing to somebody like myself who's been working in perinatal for quite a long time now. This is hot off the press as well. The World Health Organization have published a guide for the integration of perinatal mental health in maternal and child health services worldwide. And I just think this is a really amazing place to have got to, because obviously there's lots of countries in the world where perinatal mental health services aren't happening at all. So to have a document now with a guide for how to make this happen, I think this is a pretty amazing piece of work. And thank you to all our perinatal colleagues who were part and contributed to this. Next slide, please. There's a number of awareness dates coming up in September and October that we just wanted to flag. I'm sure you're aware of them. There's some big hitters in there like World Mental Health Day, but also really importantly, Black Maternal Mental Health Week, which is starting next week, and Baby Loss Awareness Week earlier in October. Okay, next slide, please. Thank you. And then lastly from me, some new resources from the Parent Infant Foundation. So there's a really nice poster there on understanding early trauma. And there's also a link to a webinar, how we talk about infant mental health, which is Sally Hogg talking about the foundation's work, and what language to use, as it says there. And I think this is a very nice segue into our first speaker for today. So next slide, please. I'm delighted to welcome back Jane Barlow, Professor Jane Barlow, who had spoken for us on a previous occasion. We had a couple of annoying IT issues, and there was so many requests in the chat for Jane to come back. And I'm delighted to say that Jane's agreed to come and speak today. So thank you so much. I think we're focusing on the Start for Life programme, and this is such a lovely presentation to give that work some real context and why it's so important to get it right from the start. So I'll hand over to you now, Jane, and thank you once again.
Thank you very much indeed. I just, you've put the other slides up. I just made some minor changes. So if you could take those down and I'll just put them up at my end, if that's okay. Sorry,
no
sorry
problem.
about that.
I'll stop sharing. Thanks.
Okay. Yeah. Okay. Mute. There we go. Does that come up for you now? Is that full screen?
Yeah, that's fine, Jane. Thank you.
Yeah, okay, perfect. Let me just enlarge that. So thank you very, very much for inviting me back. It's a real pleasure to be here. And what I'm going to do is talk a little bit about normal emotional development and think a little bit about the impact of maternal mental health problems during the perinatal period, because this really is the evidence that underpins the type of services that we really need to be providing as part of Start for Life programme. So what I'm going to do today is think about exactly what it is we mean by infant socio-emotional and behavioural development, infant mental health, in other words, and I want to explore the ways in which the evidence suggests parental mental health issues, both in pregnancy and the postnatal period, influence this. And then I'm going to conclude briefly by saying something about what I think the implications of this are for Start for Life practice and Start for Life services. So we commonly use the term infant mental health problems. Indeed, I'm the president of the Association of Infant Mental Health. So That is the the recognised term. But it really, I think many people don't quite get what how can infants have mental health problems? And so it really refers to how well the child develops socially and emotionally from birth to 3 years. That's what we mean when we talk about infant mental health. And when we talk about infant mental health problems, then we're really referring to the bread and butter issues that many of you out in the field deal with on a day-to-day basis, which is the regulatory difficulties such as excessive crying, feeding, or sleeping, and of course attachment problems that can sometimes underpin those regulatory difficulties. And we'll spend a few minutes this morning just thinking about why that might be the case. So if we think about what the prevalence of the so-called infant mental health problems are and what their stability is, the research longitudinal studies that we've now got available suggest that they're really very similar to what they are for older children. So this Copenhagen child cohort study, massive longitudinal study, found a population prevalence of mental health problems, the sort that we've just been talking about, in children aged 1.5 years to be in the region of 18%. So like older children, it's 1 in 5 children have problems of this sort, even as early as this. And of course, many of these are developmental, and one would expect them to resolve. And we actually don't have a massive body of literature that explores the stability of these problems, but we do know that, like, as with older children, they are pretty stable over time. So this study by Briggs-Gowan in the second box showed that around half of infants and toddlers showed a continuity of emotional behavioural problems over 1 year after initial presentation. And so this suggests that the issues that are underpinning these problems are really becoming embedded and need addressing. So, why is this important? We have a fairly sophisticated evidence base now that was summarised in this meta-analysis that explored the links between regulatory problems in infancy and children's later behavioural outcomes. It was 2011, so that's the most recent overview of the evidence that we have. This shows that persistent excessive crying has the greatest effect on subsequent symptoms such as externalizing problems, internalizing problems, and ADHD, with a fairly strong association between persistent excessive crying and those later issues. Feeding problems and multiple regulatory disorders are also found to be linked to general behavioural disorders. But interestingly, infant sleep problems had a less significant influence on internalising problems, but had a fairly big impact on ADHD. So, fairly nuanced type of evidence out there suggesting, a significant association, really. So this is a prime opportunity, really, for us as practitioners to be intervening to prevent these later problems. And of course, then there's the association with attachment. So we know that children who are securely attached at 12 and 24 months have much more optimal functioning, just across every single domain. So they do better in school, they're better with their peers, they're more likely to take on leadership roles, they're more confident. If you've got a secure base there, it provides you with, as it says, the security, really, to take advantage of all the opportunities that you're presented with. Insecure attachment and even worse, disorganized attachment, we know from the evidence are associated with a range of later problems. I mean, an insecure attachment isn't a disaster, and many of us started off with insecure attachments. A disorganized attachment is pretty well, disastrous in terms of the child's longer term development. But generally, an association with externalizing disorders, dissociation, PTSD, and in the case of disorganized attachment, it appears to be the basis. Disorganized attachment appears to be the basis for later personality disorders. So again, this is an optimum period really to try and promote children's secure attachment, and it's because of the etiology that the regulatory difficulties that many children experience actually are underpinned by an insecure attachment. So we know that infant mental health problems have their origins in the perinatal period, and for the better part, these are relational. So there's a prenatal pathway, which is partly physiological, but partly psychological, and also influenced by maternal mental health problems. And I'll say a bit more about that in a minute. And then there's a postnatal pathway, where the child's early relational context and very specifically the interaction with key caregivers is what influences whether they're securely attached. It also influences whether they're experiencing a range of regulatory problems of the sort that we've just talked about, and also strongly influenced by maternal mental health problems. So this is the prenatal pathway, and is my first key message this morning, which is that parenting begins in pregnancy and impacts the unborn baby via two pathways, one of which is maternal health behaviours, their presence or absence, and the second is the developing relationship with the baby. So if we unpack those two pathways a little bit, you can see we've got this physiological pathway at the top here, and this is where maternal stress or a range of teratogens have a significant influence on the programming of the fetus's HPA axis, and thereby their neurological development. And so these infants who are exposed to alcohol, cigarettes, and excessive stress, the evidence suggests that they're much more likely to have compromised physiological functioning, and also compromised emotional and behavioural functioning. And then there's this second psychological or cognitive pathway. And, I've got this little arrow here because I don't think these are just two discrete pathways. They influence one another. So if mum's very stressed in pregnancy, that may influence her capacity to bond or to develop a good relationship with the unborn baby. And the evidence shows that leads to atypical parenting, or is associated with atypical parenting behaviours, and thereby disorganised attachment. So let me just unpack that a little bit. So the evidence in terms of stress and IPV in pregnancy is very clear. Prevalence of self-reported anxiety symptoms is around 18%, which is in the first trimester, and 19% in the second, and it goes up to 25% in the third trimester. And during COVID was as high as 70%, which was very shocking to many of us. And there is very clear evidence from longitudinal studies of a strong association with later emotional behavioural problems. Less clear evidence in terms of its association with cognitive functioning. The impact does seem to be there, but it's much smaller than it is for emotional and behavioural problems. Though, of course, emotional and behavioural problems aren't conducive to good cognitive functioning. So there's an indirect pathway there as well. And of course, intimate partner violence in pregnancy. We have very nice evidence from this systematic review from 20 countries globally, suggesting that prevalence among ever pregnant, ever partnered women ranged from 2% in Australia, Cambodia, Denmark, up to 13.5% in Uganda. So even in high income countries such as Denmark and Australia, it is still shockingly prevalent in pregnancy. And again, very clear evidence of an association between such IPV in pregnancy, the onset, duration, and recurrence of perinatal mental health problems, and the likelihood that babies are going to be insecurely attached as a result of that. Sorry, that's where the picture disappeared to. And then alcohol consumption. So we know that excessive, we're talking about a significant alcohol consumption in pregnancy. There's a global prevalence of usage to be at 9.8%, but very high usage that would be linked with fetal alcohol syndrome to be around 14.6 per 10,000 people in pregnancy. And excessive alcohol consumption in pregnancy is the key preventable cause of very low IQ in children, which is is pretty shocking. And this study here that was conducted in 2017 showed that FASD is the major cause of learning disability, and also that around 50% of children in foster care have FASD. And then this second pathway is the psychological one, and it refers to how a mother thinks or mentalizes about her unborn baby. So this is her bond with him or her. And we know from this very nice systematic review that is on the next slide that this is a strong indicator of the relationship that will become established. So this was a health visitor gave this to me. She said she'd been and conducted an antenatal promotional interview with a mum that she thought was doing okay, other than her history of an eating disorder. And this mum said, when she was asked about how she felt about the unborn baby, she said, I know it's there and I know I'm pregnant, but I don't feel anything for the baby. I don't like to touch my tummy. I don't imagine it in any way. I haven't thought about what it might look like, and I don't think I'll love it when it's born, but I'll look after it and I'll love it eventually. And so this quite rightly triggered, a response from the health visitor, because she recognised that, there's very clear evidence now that, that's important at 28 weeks of pregnancy. That relationship with that baby is an indicator of what the relationship will be like in the postnatal period. I'm going to, how am I doing time-wise? Okay, Jenny?
Yeah, we've got about another 7-8 minutes.
Okay. So there are two ways of thinking of, thank you. There are two ways of thinking about the relationship with the unborn baby. There's the measures of maternal attachment, which is the emotional tie or bond. And then there are these more complex measures of mental representation, which are conscious and unconscious images and beliefs about the baby and the mum as a mother to be. And we've got very nice evidence, again, from systematic reviews that shows a significant impact both on the parent-infant interaction and also in terms of the second and third bullet points here, a significant impact on infant attachment, which you would expect to be the case, because if parent-infant interaction is affected, then there's a less likelihood that the infant will be securely attached. So my second key message then, and moves us on to the postnatal period, is that parent-infant interaction plays a key role in influencing the infant's capacity for regulation. And so that's what I mean when I say that the regulatory problems that I talk about are, sorry, my dog's got Cassie. So sorry, just one moment. That's the equivalent of Jenny's passport arriving. So that the interaction underpins the child's capacity for emotion regulation. So where the interaction isn't optimal, that's when you get to see the excessive crying, the sleep problems, the eating problems, and it's also, insecure attachment. So the very nice, very well developed evidence base to show that, what optimal interactions between a mum or a dad and the baby look like. And I could spend ages talking about this slide really, and I just unfortunately don't have time to do it justice this morning. But fundamentally, we know that, the moment-to-moment interactions that take place between a carer and their baby are characterised by moments of synchrony where they're in tune with one another, a rupture, which is normal and natural, if you like, and then repair of the rupture on the part of the parent. And that really requires the parent to be able to be sensitive to the infant's distress, and also to have some degree of what we call mind-mindedness or reflective functioning. So that needs the parent to be able to have a sense of what her baby might be feeling. And we are increasingly aware that parents who are low in mind-mindedness or reflective functioning are much more likely to perceive their baby's behaviours in concrete terms. So, they're likely to feel that the baby's hungry or that the baby's nappy needs changing, rather than to have a sense of the underlying feelings or emotional states that go with it. So, for example, one mum whose baby was persistently crying, said, she's doing this to annoy me, and didn't really have an ability to get beyond the annoyance that was going with the persistent crying to understanding, what the crying was about. And so we know that mental health problems in the postnatal period have quite a significant impact. So the evidence in relation to postnatal depression is very clear. These mums are more likely, and I should say more likely because it's not always the case. Not everybody with postnatal depression, it doesn't always impact the interaction, but it is characterised by a preoccupation with, their own depressed emotional states. And these mums are more likely to be less sensitively attuned, less affirming, and more negating of infant experience. In this third box, there's a very nice evidence base showing the impact on the baby: poorer concentration, increased negative responses with strangers, and reduced secure attachment. There's also evidence of an impact on cognitive and emotional development, and these children, this longitudinal study by Lynn Murray showed that these children of mums who were significantly chronically postnatally depressed were 42% more likely to be depressed themselves in adolescence. Similar with borderline personality problems, this is a problem with mentalization and with unresolved states of mind. So this systematic review by Lawlick showed less structuring in the interaction. The infants were less attentive, less interested, less eager to interact with their mum. There was lots of disrupted communication and frightened and disoriented behaviours. And this increases quite significantly the likelihood of these babies having a disorganised attachment and an inability themselves for mentalisation, with an increased likelihood of personality disorders and significant regulatory problems in the long term. So these are the sort of, this slide shows the sort of atypical parenting behaviours that we can see, you know, at their most extremes. So, you know, this is referred to as FR behaviour, or hostile and helpless. So this refers to behaviours where the parent is both frightened and frightening. So they're, you know, they're distressed themselves, and may have moments when they appear very timid and deferential or dissociated, and then they move seamlessly into being frightening, and you know, they can loom into the baby's face and shout at them. That their interactions are disrupted and they don't get repaired, and they're often evidence of what we call effective communication errors, which is where the mother is out of sync with what her baby's feeling. So the baby might look distressed and mum is laughing at that. And very nice meta-analysis that shows a strong association between these sorts of atypical behaviours and a disorganised attachment at 12 and 18 months. And the prevalence of that in areas of significant disadvantage is very high. It can be up to 40–50% of children with a disorganised attachment. So finally, key message 3 is that we know what to do. And so I'm very much hoping that this is going to, the fact that we have evidence, and it does provide us with very clear messages in terms of what we need to be doing to enable every parent to give their baby the best start in life. We really need our Start for Life services to be providing interventions that address these. And I think fundamentally this means identifying in the first instance, and I don't use the word screening because we don't screen for relationship problems, but where we have screened for mental health problems, because we have a screening program for that, we should also always be thinking about, are there problems in terms of the relationship with the unborn baby, as well as, the impact of the mental health problems on the mother herself. And so the sorts of services should not only include treatment for the mother's mental health problems, but should involve an intervention either prenatal, and there's a whole host that I could talk about, but I'm running out of time. But these are activities to promote the bonding with the unborn baby, and we've got some very nice evidence about what works now. And postnatally, again, we've got very nice evidence: infant massage, video feedback, circle of security, that really support the relationship with the baby. So this slide just summarises my key messages: that perinatal period is absolutely key in terms of optimising infant development and giving every child a best start in life. And so Start for Life services really are, a fantastic opportunity to intervene in ways that we haven't been able to date, particularly in terms of the 2 pre- and postnatal pathways, and what we now know about the impact of maternal mental health during those 2 periods. And also because we're in quite a good place now, really, in terms of the evidence and knowing what we can be doing to make a difference and to really give every baby a best start in life. Let's stopping there.
That's brilliant, Jane. Thank you so much. So much there that we could discuss, but I am going to ask for questions to go into the chat, please. And are you staying around, Jane, to be able to answer any questions that come up?
I can stay till 11. I was wanting to listen to the next presenters and stuff, so
brilliant. Well, I don't think we could have set that up any better to give us all, if it were needed, and hopefully on this webinar we don't need to be told why early days work is so important. But if we did, I think Jane's just told us exactly why it's so important to get it right at the beginning. So I'm going to now hand over to John Bales. Is that the right pronunciation, John?
It is, yes.
Your Bales, yeah. To John Bales, who is the Start for Life Mental Health Policy Lead, and he's going to tell us about the Start for Life programme that is going to be starting in a lot of your areas for people on the call. So I'll hand over to you, John. Okay, thank you very much.
Thank you, Jenny, and thank you, Jane, for setting it up so nicely. I'll just share my slides. Okay, can you see that fully? Yeah.
Yes, thank you, John.
So this morning I'm going to outline the government's vision to give every baby the start for life, which was set out last year, and then give an overview of the investment in the early years services in England, and then give a more detailed update on the Start for Life programme. So yes, it was in March 2021 when the government published the Best Start for Life, a vision for the first 1001 critical days. That was after a review that had been chaired by Dame Andrea Leadsom. And there was 6 action areas identified through that review and set out. So firstly, more seamless support for families, knowing that for any parent, trying to navigate and understand what's going on in your local area can be really difficult. So making services more joined up and seamless, providing a welcoming hub for families. So a physical place where families can go and find out more about services, and as well as the digital element as well, and finding out online. And then in terms of making that service a reality and making it really effective, ensuring there's a really empowered workforce, and developing the skills further to meet the changing needs for families, and thinking about those attachment difficulties that can occur, which Jane talked about, and continually improving the Start for Life offer. So with investment, really getting that evidence base when the programme is in place. And then finally, thinking about the leadership that's needed for change. So ensuring that there's good local and national accountability in place. So what does the Start for Life and Family Hubs programme look like in terms of investment? A large part of the funding in place is for a network of family hubs, which I mentioned. So that's a physical location, as well as there being a kind of a virtual offer where families can identify where support can be provided. Funding for infant feeding support, knowing how important that is, not just for nutrition, but also bonding between babies and mums. Funding for parenting programs, and Potter funding for workforce trials that will be done in 5 local authorities from next year, to really explore what the best case for skills mixes are in terms of future investment in this area. And then £100 million, this is for the next 3 financial years to March 2025, for infant parents' mental health and relationship support, which I will go into a bit more detail. So in terms of local authorities being eligible, it's 75 local authorities, and that's done on the basis of the most deprived local authorities, with a weighting for 25% of the different urban to rural classifications, so that we're not in a position where perhaps it would all be inner city local authorities, but also a good mix with some more rural local authorities. So for the southeast, I have East Sussex, Isle of Wight, Kent, Medway, Portsmouth, Southampton. My understanding is that Croydon is in London technically, but do correct me if I'm wrong. So then thinking about where investment could be most helpful in terms of developing the programme, we really wanted to complement what the existing investment and services through the long-term plan. So knowing that there's really good support in place for more moderate to acute needs in terms of perinatal mental health for mums, some limited support in place for dads and co-parents, but knowing that we could go further. We identified three main focus areas. So perinatal mental health support for dads and co-parents, support for parent-infant relationship difficulties, and noting that there's around 42 parent-infant relationship teams currently working in England. So in some areas we get competition for some of the same resources practitioners who are also delivering long-term plan commitments. So in terms of developing local authorities working with the NHS and third sector, the potential competition for some of the same resources practitioners who are also delivering long-term plan commitments. So as a result of that, we came up with a sort of three-pronged approach, with the bulk of the funding for local authorities to tailor as they need to, acknowledging that different local authorities are starting from different starting points, and then supporting that at a local level through national initiatives. For example, National Centre for Supervision to support training and remote supervision when that's not in place, when that expertise is not in place locally, and training to improve workforce capability. So the Start for Life programme will be delivered through family hubs, and I want to take a moment just to give a bit more detail about what that means in practice. So family hubs are a place-based way of joining up locally in the planning and delivery of local services to put families at the heart of support. And there's three main guiding principles to how they will operate. So in terms of access, making sure that family hubs are really clear, simple points of access for help and support. Family hubs being a real point of connection between different services and professionals working together, and relationships, and developing that from the word go when parents come into a hub, parents or carers, and meet someone at reception and then start a relationship from there. And a family hub can be a physical location, which there'll need to be physical locations, but it doesn't mean that all services are delivered in that building. So some of the services will be, but some of them may be delivered elsewhere. And there's also a virtual offer, and that can be sort of static information about what services are available, but there's also the option, of course, to deliver services virtually. And in terms of minimum expectations for how family hubs will operate, from a perinatal mental health and parent-infant relationships perspective, we felt it's important for family hubs to have a designated space for wellbeing and mental health conversations. information and leaflets to be readily available in person and online, and antenatal classes to include advice as standard on mental health, and to ensure that staff are appropriately trained on perinatal mental health and parent-infant relationships. And then in terms of supporting practitioners in delivering the programme, I should caveat that the exact details are still being worked through and developed, but this is the kind of broad parameters that we are envisaging. So training will be given at 3 different levels of depth. So the first level is increasing awareness and identification of difficulties, as Jane talked about earlier. So through a national centre for training and supervision, being a potential resource for training for all frontline practitioners working with babies. For example, training could potentially be around trauma-informed care or more father and co-partner inclusive practice. That's the first level. And then the second level of training would be aimed at practitioners who can offer more support for parent-infant relationships. So thinking perhaps of health visitors, social workers, psychology professions. And that would be delivering, we envisage at this stage, evidence-based interventions to support parent-infant relationships. So, for example, strength-based video feedback sessions and reflective one-to-one or group sessions. And then finally, a third level that sits above that would be increasing supervision capabilities. So again, recognizing that some areas may not have sufficient capacity and expertise in supervising parent-infant relationships support, providing that training for a small number of practitioners to increase local capability. And that would be aimed at more experienced clinical practitioners, such as psychologists or psychotherapists. And as I mentioned earlier, so the bulk of the funding is going directly to local authorities who would have flexibility in how they go further and develop and provide more perinatal mental health or parent-infant relationship support. And there's 4 categories of different ways which that could be achieved. So one is parent-infant relationship support. So it may be that there's a team currently delivering activity, but it may be expanding the geographic scope or who can be referred to that service. For peer support, it could be expanding an existing service with the third sector, or it could be doing a whole new service. In terms of perinatal mental health, so looking at more support for dads and co-parents and for milder difficulties for mothers. And then the final category is enhanced health visitor and midwifery support, knowing that those professions are really well placed in terms of spotting, identifying attachment difficulties and providing interventions. So it could be funding for additional training and enabling those professionals to carry out consultations to their teams or provide a small clinical caseload. And then finally, in terms of next steps for the programme, a programme guide was published last month, which was quite a big milestone. And now eligible local authorities are signing up for funding, and it's been really interesting seeing all the sign-up forms and seeing what the plans are, and it's really starting to come to life. And local authorities will be developing plans for delivery later this year. And local authorities are expected to publish their Start for Life offer for families by April next year. And we anticipate that national initiatives which still the details need to be fully confirmed, but such as the National Centre for Supervision will launch next year also. And as I mentioned early on, the current funding runs to March 2025. And so during this period, really focused on developing the evidence base and the impact of the programme as much as possible. Thank you very much, and I'm really happy to take any questions.
Thank you, John. Liz, can you just confirm for me how we're doing for time? I'm such a hopeless timekeeper. I'm never sure if we've got time for questions or whether they need to go into the chat.
Sorry, I'm just trying to do the right controls. We are dead on time. Thank you very much to our speakers. So it probably would be good if we could put the questions in the chat, or maybe have room for one question whilst I share my screen for the next presentation.
Oh, there is one in the chat from Caroline from Kent about the bulk of you said that the bulk of the funding is going to the local authorities, and Caroline's just wondering where the rest of it's going to go.
Yes, so it would be to national initiatives like the National Centre for Supervision, potentially a public health campaign to raise awareness, so things like that.
And one from Diana from Sussex about if other counties can apply to be part of it. So Diana's saying West Sussex, because we know East Sussex did get some of this funding or was identified as an area. Oh,
yes.
somebody's...
So it's for this 3-year cycle, it's just on those 75 local authorities at the moment.
And Hema in the chat has got their hand up very politely. So do you want to ask your question, and then we'll make that the last one?
Thank you. I was just typing it. It was just to ask John, really, the funding in terms of staffing that you've mentioned for local authorities. So I'm from Kent, John. In terms of funding and using it for workforce development, that's fine. But if you talked, I don't know if I got the sense that you were talking about we could recruit new teams, but obviously after the funding ends, we would have to find the funding for those new services. Have I understood that correctly?
Yes, that's correct. So that would need to be factored in terms of sustainability for long-term funding.
Thank you. That's really helpful.
And there's one more question in the chat, John. Can I ask you to answer that one in the chat? And I see someone else's hand has gone up. So again, could you, whoever you are, could you put that one in the chat, and John will answer that if that's okay. John, can you do those ones through the chat?
Yes, very happy to.
Lovely. Okay, so I'm going to go on to our last speakers. So Jane gave us the why of Start for Life and why it's a good idea to start so early. John's just given us the what in terms of the programme and some of the detail around that. And now we've got Better Start Bradford and the Bradford Infant Mental Health Service to show us the how. And these are, so Kerry and Charlotte are people that are already walking this walk and going to show us how they've interpreted it. So over to you two, Charlotte and Kerry, and thank you so much for coming.
Thank you for the invite. Good morning, everybody. My name is Kerry Bennett, as it says on the slide, Integration and Change Manager with Better Start Bradford, and my colleague Charlotte.
Hi everyone, I'm Principal Clinical Psychologist and Infant Mental Health Pathway Lead for Bradford District Care Trust.
Fabulous. So yeah, so today our aim is to give you a high-level overview of the Better Start Bradford programme and the Little Minds Matter service. And as we've just said, I know there'll be lots of questions, so this is sort of the open door for us to give you some information this morning, but please do get in contact with us for more sort of detailed information as required. So that offer is absolutely there. So probably we're just going to reiterate a little bit of what John just talked about there, and we just felt that we needed to acknowledge that as our brief was today to discuss our service in relation to the Start for Life agenda, we felt it was necessary to acknowledge that every local authority area will be starting from a different position, a different point, and will have different local needs, assets and existing provision to consider. As you will have just seen on that list, that Bradford is one of the first 75 local authorities who will be receiving the Start for Life funding package, which we were very excited about. So we are currently working up our or developing our plan of delivery as an integrated approach, and absolutely utilising the learning from the Better Start Bradford programme to help offer some foundations for our thinking in that. Okay, next slide, please. Okay, so before I hand over to the expert Charlotte to talk about the Little Minds Matter service in more detail, we felt it would just be useful to give a little bit of context this morning to help explain how we've arrived in our current position of being able to deliver the service in Bradford. So next slide, please. So I'm sure many of you, and I hope many of you will know about the Better Start programme in England. We are one of 5 national sites funded by the National Lottery Community Fund. Our sister sites are Southend, Blackpool, Lambeth and Nottingham. And we went through a bid process in 2015 for an application with our partners in Bradford to secure funding for 10 years. Our collective aim for all 5 Better Start sites is to improve life chances for babies and young children. And in Bradford, we are focused on 3 wards of Bradford, so it's not the whole geographical area of Bradford. Our application was around the 3 most deprived areas at that time in Bradford, but we're very aware that 14 of our wards in Bradford fall into that 10% most deprived areas in England. So all the 5 Better Start sites that have a slightly different arrangement. We have a community anchor, which is Trident, and then, like I said, that it's a partnership approach, and very much in partnership with our community members and our parents as equal partners. Okay, next slide, please. So all 5 Better Start sites have 3 core themes, which are shown here, around social and emotional development, language and communication skills, and health and nutrition, with that overarching aim that we will support system change in the way that health, our public health services and our voluntary sector look at delivering services in the future. Okay, next slide, please. Okay, thank you. We are going to obviously focus, and we've been asked today to focus on the Little Minds Matter service, but I just wanted to give you that overview that we commission nearly 20 different projects ranging from services for expectant families to families with children under 3. So a broad range of projects that we are working closely with our evaluation partner, which is Born in Bradford. And all our projects go through a rigorous service design process and an evaluation process, obviously, to be able to support that broad system change that I spoke about. Next slide, please. So like I say, so Better Start Bradford, we are in our 7th year and very much in our delivery and evaluation stage. We are moving our thoughts to our sustainability and legacy and working with our local commissioners to look at identifying our gaps in our offer and to be able to talk to them and align commissioning plans. We're absolutely in a great position to be able to add our learning and support, especially now the Start for Life planning and what that offer will look like for Bradford, and really be able to tailor it to the needs of our local community and population. Like I say, Little Minds Matter is one of those commission services that went live in summer of 2018. It's provided by our partners of Bradford District Care Foundation Trust, and the service sits within their CAMS services. It's also delivered in partnership with our third sector partner, Family Action, but we also work very closely with the 0 to 19 service that's also provided by Bradford District Care Foundation Trust. So the everyday challenges such as being able to record on System 1 and all those operational difficulties, that we do find ourselves in a good position there, and I know Charlotte will talk a little bit more in detail about those partnerships. So like I say, I think that's my time to hand over to Charlotte to really talk about in depth around the learning from our Little Minds Matter service to date.
Thanks, Kerry. Could we go on to the next slide, please? Thank you. Okay, so yeah, we are one of 39, 42, depending where the website's updated on the Parent Infant Foundation website, but we are one of only a small number of specialist parent infant services. And one of the things that I think is really, and again, like somebody said at the beginning, I don't think we are telling you anything new here, but there is a real case for investing in these specialist services, because although we have the nationally commissioned perinatal services, even when they are funded in the way that they're supposed to be, and not in every area are they kind of given all the funding that they're supposed to be given, they only work with 10% of mums usually. With some expansion potentially to other parents. But as was in the chat earlier, we are potentially looking for specialist services that looking at working with 50% of families who either have a insecure attachment, disorganized attachment, or risk factors for mental health problems in the future. Next slide, please. And again, thank you. So yeah, Little Minds Matter. We have 4 strands, and I think we're quite unusual in this. I don't know of another specialist service that has the community engagement strand. If anybody does know of one, please let us know, because we'd like to link in with them. But this was definitely something that was thought up by Better Start Bradford, which has been really invaluable to our service. So Bradford is a very diverse population. And we, BSB, wanted to kind of make sure that we were able to share our key messages with the community, but also that communication would go both ways. So we would be going out and actually finding out what families wanted from our service. So we have a community engagement worker who is employed by Family Action, and that's the collaboration that we have there, and she leads on that strand. So she does our social media campaigns, and she also goes out to family events and things like that. And then the rest of it looks a bit more like a lot of the other specialist services do. So we deliver training, we offer consultation, and we offer direct clinical work. So if we go on to the next slide, I think I'll talk through each one in more detail. So these are our key messages. So the community engagement strand promotes our key messages, and as I said, kind of gets some messages back from the community as well. So our key messages are that parent-infant relationships matter, that babies can't wait, that babies are born ready to relate, and that support networks matter. Next slide, please. Our training packages. So we offer training to any professionals. We also have offered it to volunteers, students, foster carers, anybody who has significant interaction in a non-parent, non-carer capacity for babies or pregnant women. So our core training package is a full day of infant mental health awareness. So this is baby brain development, bonding, attachment styles, attachment theories, everything that you would expect within an awareness day for infant mental health. We then have a half-day follow-up. So you have to do the first, do the second, and we call this infant mental health in action. And this came about from a need to, some of our feedback was about kind of basically, okay, this is great, but what do we actually do in practice? So what we do for this half day is a smaller group, it's more seminar style, and the attendees will essentially watch videos, and this is quite tricky because videos, trying to kind of access videos on YouTube and the ethical considerations around that are sometimes quite tricky. But essentially, the attendees on the training will watch those videos, and then we'll have a discussion about what might be going on for that family, and we'll think about if that was within a context of, and this is really important, that is a frequently observed behaviour and not just a one-off, because none of us are perfect parents. But if that was a kind of frequent experience that professional was having with that family, then would they offer some sort of intervention themselves, or would it require a referral on to us as a specialist service? So yeah, really really helpful training package, I think, for professionals, that one. We also have a short, this was developed during COVID to kind of help us keep in touch with the workforce, 90-minute training program called Tuning into the Parent-Infant Relationship, and we did deliver that live over Zoom and Teams, etc., during COVID, and then it's now being digitalized, which is taking a while from the IT perspective, but that will mean that people will be able to watch that in their own time rather than us running live sessions for that. We also offer tailored sessions, so we present alongside the Leeds Infant Mental Health Service, which is our most close neighbour in terms of a specialist service, who don't have the Start for Life funding, unfortunately, but we jointly deliver some training to the trainee clinical psychologists. We have a short programme which is offered as a virtual placement, so it has some pre-work, some training, and then some post-work to nursing and allied health professional students. We have a tailored package for our neonatal ward, there is one in Bradford, and then the 0 to 19 service and our specialist health visitor have been developing and have started to deliver the voice of the child training, which is really key. So yeah, a real breadth of training that we deliver. Next slide, please. Oh, have we missed a slide? Did you? Nope. Okay, could you try? Sorry, go on two more. I wonder if that one's disappeared. No, it hasn't. Okay, go back. It's fine. I'll make it up. So we deliver 4 types of which is what the slide that I thought was on here. I'll send that around if it's been missed. So we deliver 4 types of consultation. So just spotted in the chat, yes, the 0 to 19 service do have a specialist perinatal practitioner who we work closely with. Yeah. So we have 4 types of consultation. The first one is basically a triage type one-off, basically ring us and we'll talk to you, is kind of our first consultation. So we're happy to chat to anybody who phones us about a family. And then we have 3 more formal types of consultation. So one of them is ongoing consultation, and this essentially is for those families, for the professionals working with the families, where the families fall outside of our remit. So basically, if we can't accept from the direct clinical work, but we'd like to, then we offer direct ongoing consultation, and I'll go on to talk about our direct clinical work in a moment. So that's that essentially, and then it's a team around a child type approach where we will guide the professionals through holding the infant in mind and thinking through what might be happening for that family. We also offer what we call attachment matters drop-ins. So this is just a slightly more formalised version of our kind of triage calls. So we used to run these face-to-face, so we would sit in the children's centres and people could drop in to see us. That's obviously virtual still at the moment. Our trust is very much still on virtual working, hence being at home. But yes, so they're just a little bit more formalised. So we invite people to come and talk about family, or to just discuss anything that we can, if they were interested in measures or interventions, then we can kind of talk people through those as well. And then our last form of consultation is our reflective discussions. So this is where we work with teams. So we have a team of health visitors. We also work with the doulas service, which is a voluntary service run by BSB as well, commissioned by BSB as well. We offer it to the IAPT perinatal specialists. We are starting it with the midwives, although they will probably look a little bit different because of how they work with families for such a short period of time, and various other services and teams as well. This is the hardest to set up because people are very, very time pressured, but it receives very, very positive feedback when it is set up with services. So what we do there is that we ask one member of the team to present a case, and there'll always be 2 of us. We try and do it so that it's one qualified clinician and one of our trainees or assistant psychologists, just to spread the load in terms of our qualified clinicians. But we do have some that are run by 2 of our qualified clinicians. There will always be 2, and the reason for that is that we pick up on different things. Somebody can focus on writing the notes, while the other person is a little more engaged in the process. Really tricky to do on your own. And then we have a team of, usually we'd ideally like kind of 6 to 10, 12, but sometimes it's a little bigger, sometimes quite often a little bit smaller. And we will use a reflecting teams approach for that. So we will, our first session with the team is usually explaining and modelling what this might look like, so that everybody really gets into the ethos and the way of being reflective, and not questioning, and not because if we ask too many questions in those environments, it tends to just lead to information giving on the part of the person bringing the case, as opposed to actual reflection. So there's some kind of examples of the questions that we might use there. I won't read them out because you're going to get these slides anyway, but yeah, they're the kind of, that's the tone that we would use in those sessions. Next slide, please. So our direct clinical work. We work with anyone who is pregnant or has a baby under the age of 2. We work with anyone where there are concerns with the parent-infant relationship. So sometimes these might be explicitly stated by the parent. Usually they're not. Usually they are professional concerns, or we know from looking at the family's risk factors, essentially, that intervention would be a good idea at this point, because if we don't, then that family might be going down a certain path and our interventions might help them go down a different path. So we're very, very accepting, essentially. We accept almost all of our referrals. Our geographical area is very, very complicated. So we were initially commissioned by Better Start Bradford, and that, as Kerry said, covered 3 wards within Bradford. I'm not from Bradford, and it took me a while to get my head around this, but it's actually a really tiny part of Bradford. Very needed, very much needed our services in that area, but a very tiny part of Bradford. We then, about 2 years ago, got some additional funding from our Reducing Inequalities in Communities funding, and that expanded us out to another area of Bradford. So our areas now essentially is BDs 1 to 9, except for BD 4 and half of BD 6. So it's really rather complicated. We have a map, and I hope if you're setting up services, you don't have to set them up in such a complicated way in terms of geography. But that's where we're at the moment. And we work with any carers. So we don't just work with mums, we work with some dads, not as many as we would like, but we do work with dads, we work with foster carers, etc. So we work with any carers. Our team is ever growing, because we started off with just our BSB funding and have grown with our RIC funding, and then delays in getting started has meant that we've sometimes had an underspend as well, so I've been able to expand based on that as well. So we have therapists right from kind of assistant psychologist up to myself. In terms of mainly psychologists, we do have a family therapist who's one of our clinical leads. We always advertise for psychotherapists, but we do seem to struggle to recruit, which is unfortunate. We would love one in the team. We have both a specialist health visitor and a health visitor within the team, and a specialist midwife. And then we have community engagement worker who also is a community support worker. And we have a full admin team, which is great because we used to run on very minimal. How many people in the team? There will be but 5 new starters in October, but 2 of whom are trainees. So there will be about 14, 15 of us from October. We are a big team. I used to refer to as a small team, and I don't think I can do that anymore. We are very much growing. So yeah, I think we're probably one of the biggest specialist services in the country that I'm aware of. Certainly in England, I think there is quite a big one in Belfast, I think, or somewhere in Northern Ireland or Ireland. But yes, we are quite a big team now. Sorry, I'm seeing some of the messages as they pop up in the chat, but not all of them, so I'll go back through afterwards. Could I have the next slide, please? Well, this is small. Okay, so one of the key things about specialist services is that because we are working with the baby's needs, essentially, we're focused on the infant mental health, that in terms of where a family might fit in a 0 to 19, which is the universal to specialist level, or if you're from a CAMHS world, a tier 1 to tier 4 sort of level, is that we're across the board, really. Obviously, if a family is truly universal or truly tier 1, if you're using CAMHS lingo, then they don't need specialist services. So that we're not working with those families. But we offer interventions right from a universal plus right up to a specialist level. So at the Universal Plus level, these are the families that will benefit from some information around infants' emotional and social needs, around some psychoeducation around brain development, states and cues, things like that, who just need a little bit of support to build a secure relationship with their babies. So the interventions that we offer along those lines is our Circle of Security group intervention. We do offer it individually when needed, but we're trying to offer it as a group as much as possible. Kind of specialist health visiting and midwifery, our community engagement, community support worker, some kind of adult therapies. So our trainee psychologists, our assistant psychologists might deliver some of those more manualised therapies, CBT, for example, we all deliver psychoeducation. We also have people who are Watch, Wait and Wonder and Watch Me Play trained within the team. And then we're moving up to our targeted families. So the families who would benefit from adult mental health support. These might be the families who've been in IAPT previously. They might even have been in community mental health teams, for example. So they might need some support around increasing positive interactions. They might have experienced trauma, ACEs, etc. So we obviously, everything below can also be offered at each level, and we often, Circle of Security is actually offered to a huge number of our families, either as the first intervention or as the last intervention within a package of care. We also have somebody in the team who's EMDR trained. A lot of the clinicians are video interaction guidance trained, which we love and would like to use all the time. We have somebody who's TheraPlay trained. We have a family therapist within the team. And then we have the families who require a really specialist level of support. So these are the families who've experienced significant trauma. And we have somebody who's trained in an intervention called child parent psychotherapy. It's not used a lot in England. It's come from America, but it's another real trauma focused approach. I'm talking a lot, aren't I? Next slide, please. I'll try and make this briefer. We link really closely with our other perinatal and infant services, so the 0 to 19 service, which does have a specialist clinician working within it. There is also the specialist mother and baby mental health service, which is our specialist perinatal service. It's called that because of other organisations within Bradford, so that's why it's called SMABS, Specialist Mother and Baby Service. And then we're quite unique in Bradford, and we have a specialist 0 to 7 service within CAMS. They predominantly work with families who have experienced significant trauma and are on child protection. So there is sometimes some confusion about who to refer to, but actually it's relatively clear cut. We work from a Universal Plus to a specialist level, usually not on, we don't work with families who are on child protection, and they do work with families who are on child protection, but we're very lucky to have both. Next slide, please. Is this you, Kerry?
Get myself off mic. Yeah, that's me, and thank you. I one of my slides landed in your pot as well, Charlotte, so thank you for styling that out very well. Okay, so I'm conscious of time, so I'm just going to sort of wrap it up before we do contact details and time for any further questions. So I hope we've been able to sort of show how that, you know, it can work in practice and how it is working in Bradford to offer that truly universal and preventative offer. That our next steps are that we will be hopefully be successful as one of the trailblazer sites. The application process is happening now as part of the Start for Life offer, because we feel that we can clearly demonstrate that Go Further offer and showcase that and support other local authorities to be able to think about their offer in this area. And yeah, I think next slide, please. Very conscious of time. I think we just wanted to finish on just some top sort of takeaway.
Yeah,
points.
This was just,
yeah.
I mean, we didn't obviously know that John was going to be delivering that as well, so you've probably had most of this already, but this is just my take on what Start for Life, the minimum expectations are. Not everything is on there, but in terms of some of the specifics for parent infant services, and then the Go Further offer. Obviously expanding or developing a specialist team is in there, I think with a big caveat that recruitment might be quite difficult. So if that is something you're looking to do, then I'm happy to have those conversations with you. That's no problem at all. The ones in bold I just put there because I'm aware that there'll be some people that aren't in a Start for Life eligible area on the call, and that my sense is if you do want to have some input and want to increase stuff, then those two in bold would be a great place to start. If you can, without the Start for Life funding, that if you can have some input into antenatal classes, which vary hugely across the country, and if you can deliver training, deliver something like our infant mental health awareness training to the workforce, then that would be a great start, even without the Start for Life funding. But I know that's very, very difficult to do.
Next slide, please. And I think we're already getting asked for further information. Absolutely. The door is open, like I said at the start of the presentation, to either myself or Charlotte for more detail. So that's our general information for the Better Start Bradford programme. And then the slide that follows is Charlotte's details for the Little Minds Matter service. So I understand that the slides are going to be shared, so you will have those details. So yeah, please do get in touch and let us talk to you more. Thank you.
Thank you so much for such a fantastic presentation, and to all our speakers today. Such an amazing service, and I'm sure lots of people will be in touch. I know Jenny and I have been messaging each other, certainly want some more information on various aspects. So thank you all. Thank you for everybody to attend today. Just a reminder, I'm really mindful of time, so just a quick plug that our next webinar is on the 19th of October, and as I mentioned earlier, will be on provider collaboratives. So please do attend that. Obviously, the recording will be available following, should come out in the next couple of days, as well as the slides as well. So apologies that it's a quick finish, but in order for you to get away on time, thank you very much for attending, and we'll see you next month. Bye-bye.